Hello students and welcome back to my channel. This is the Children Nutrition series of videos. And today we're going to continue by talking about the gastrointestinal related diseases. So expect to learn the chronic inflammatory bowel disease as well as the constipation, reflux and malabsorption together with the cystic fibrosis and the dysphagia. Hi, I'm Tommy. I'm a human nutrition student and researcher at the university. What I do in this type of videos is to synthesize my classes so then I can explain and teach you the best and most valuable information you need to know. So let's begin by talking about the chronic inflammatory bowel disease. So the overview. These are two disorders of unknown etiology. They are defined according to the clinical, radiological, endoscopic and histological criteria. Inflammatory activity affecting the intestine. This is the common thing between the two. And alternating with latency phases. These are the Crohn's disease and the ulcerative colitis. The Crohn's disease is transmural involvement. Any segment of the gastrointestinal tract can be affected in a discontinuous manner. On the other hand, the ulcerative colitis is exclusive involvement of the colonic mucosa. It has a variable extension, predominantly distal, and in a continuous manner. So it usually starts near the rectum and it goes up the colon. Etiopathogenesis is not clear. It involves genetics, environment, dysregulation of the immune system. And there is a very important role of the microbiota and diet, because the diet can also influence the microbiota, which can change the immune system as well. The epidemiology is increasing worldwide, especially the Crohn's disease, and it is related to ultra-processed food. There is a possible nutritional repercussion and effect on growth. And it has an impact on social and emotional sphere of the affected individual. The diagnosis, we have to follow the Porto criteria. There must be a clinical suspicion and an indirect analytical data, such as iron deficiency anemia, increased acute phase of reactants in blood or feces. And to do that, we do a gastroscopy and ileocolonoscopy with biopsies, together with a magnetic resonance enterography. The treatments, well, we have an immunosuppressive therapy as a basic treatment. Immunosuppressive. It improves the natural history, but there is a risk of side effects, such as infections and tumors. The dietary treatment is the importance of the diet. The diet can change the microbiota and the permeability of the intestine, modulating the immune system, stimulation, and indeed controlling the tissue damage. It's very important, our diet. There is an exclusive enteral nutrition diet or a Crohn's disease exclusion diet. The enteral nutrition is an administration of a sole polymeric formula during 6 to 8 weeks, the first line therapy for mild to moderate inflammatory flare, and it has similar or superior efficacy to corticosteroids in inducing the clinical remission. It has a greater efficacy in achieving mucosal healing. The advantages are improved growth, it promotes bone mineralization, and is free from significant side effects. The problems, though, are the tolerance, the discontinuation due to palatability and monotony of the diet, the decreased diversity of intestinal microbiota, and an induction treatment, not for maintenance. And you have to know that there is a non-efficacy in partial enteral nutrition, so when we combine the enteral one with the diet, because the effect is obtained by the exclusion of some elements in the diet. And these are the saturated fats, the maltodextrins, which are additives, red or processed meat, wheat because of the gluten, low fiber, emulsifiers or additives, and carrageenans, which are additives again. As you can see, things that are mainly present in high processed food. On the other hand, the Crohn's disease exclusion diet is a standardized diet divided into 3 increasingly permissive phases. It is based on unprocessed fresh foods, rich in fiber, complex carbs, quality proteins and healthy oils, combined with a variable amount of polymeric formulation. And it avoids processed packaged food, together with saturated fats coming from animals, refined sugars, meat, milk and gluten. It also avoids additives such as emulsifiers, carrageenans, maltodextrins, titanium dioxide, etc. and artificial sweeteners. The phases, as we mentioned, are 3. Phase 1 is from 0 to 6 weeks, and it is the strictest. It is a polymeric formula as extra nutritional intake to cover 50%, so half of the calories are coming from the formula. The phase 2, from 7 to 12 weeks, there is more food included, so the polymeric formula as an extra supply to cover the 25% of calories. And the key to successful remission of the inflammatory flare-up and correction of the dysbiosis are indeed these two phases. It's the most important, the exclusion of non-permitted foods. And on phase 3, we have maintenance. So it's clinical remission and conceived as a lifestyle. The polymeric formula will cover initially 25%, so coming from the phase 2, subsequently not necessary, so we can stop using it. It is more permissive and it has no compulsory foods, but maintains some prohibition, following these key foods right here. So the conclusions on the Crohn's disease exclusion diets is a remission of the 70% of the individuals, which is good. Useful for maintenance, good for newly diagnosed but also advanced patients. No adverse effects. We eat real food, so there is a better tolerance and compliance. It promotes a healthy lifestyle. We have to choose a good family support, but we can encounter a primary non-response or maybe a loss of response as we continue. So these are things to take in account before implementing it. We also have to mention that the treatment for ulcerative colitis is not established yet. So now we talk about reflux, constipation, and malabsorption. The reflux. We have the gastrointestinal reflux and the gastrointestinal reflux disease. It is the passage of content into the esophagus with or without regurgitation and vomiting. So it gets back into the esophagus from the stomach. Considered a disease when it interferes with daily life. The general symptoms are discomfort, failure to thrive, refusal to eat, the Sandifer syndrome, and caries. It can also give gastrointestinal and respiratory symptoms. The red flags are, as a general rule, lower weight, lethargy, fever, excessive irritability. At the gastrointestinal level, the persistent vomiting, nocturnal bilious vomiting, hematemesis, chronic diarrhea, and abdominal distension. And from a neurological level, the center of vomiting. Clinical diagnosis and tests. The clinical diagnosis is a medical history and physical examination. Again, remember the ABCD. Others are not routine. If further studies are needed for the diagnosis, we can use the barium contrast and abdominal ultrasound. And this one is very interesting. The upper digestive endoscopy with biopsies, which is called the esophago-gastroduodenoscopy. So from the esophagus to the gastric, to the stomach, to the duodenus, to the intestine. Trials with proton pump inhibitors are a treatment we can consider. We have to do a pH impedance to see if it is acid or alkaline, the reflux. And it detects liquid, solid, and gas as well. We have to record all the reflux episodes throughout the day, and it is used to differentiate the non-erosive reflux disease from the esophageal hypersensitivity and the functional dyspepsia. The non-pharmacological treatment is using thickeners to improve the regurgitation, safe even to include in children's formulas, reducing the meal volume to avoid that regurgitation, the elimination of cow's milk proteins from 2 to 4 weeks in the mother, or extensively hydrolyzed formula. The postural therapy as well is very interesting, so it's not recommended in infants, only in older children, and it is advisable to raise the head of the bed. So this is done to eat in a proper posture. And other types of non-pharmacological treatment are general things, such as avoiding heavy metals, no tobacco, no alcohol, avoid obesity, and there is no evidence that the use of probiotics will improve the condition. Pharmacological treatment and surgical treatment, on the other hand, we have the acid suppressive therapy using H2 antihistamines and proton pump inhibitors. This is the omeprazole. And we have to be careful because this will create an hypochlorhydria. It will alter the microbiota, the digestion, and the nutrient absorption in the child. So it may lead to a growth failure. Antacids and alginates, they have not shown improvement. And we have to be careful with them because of the aluminium salts, which can contribute to the serum aluminium that can build up in the brain and indeed create diseases and problems. Prokinetics, the metoclopramide, the domperidone, and the erythromycin, they are prohibited or very restricted in pediatrics. This is because of cardiological safety. And the surgical treatment is using a fundoplication. This is basically creating a knot around the cardias. This improves significantly the situation, but the survival rate is only 60%. And the reoperation is required in 20% of the cases, and you still have to continue using omeprazole anyway. So the conclusions are that there is no gold standard. It's good to start with non-pharmacological treatment. There are many complementary tests that are not routine, and the proton pump inhibitors must be taken for 4 to 8 weeks and then reevaluate. Then we have constipation. Definition and etiology. A child can be very constipated and have a bowel movement every day. So you have to know that frequency is only one factor of many to consider constipation. The others are size, pain, diameter, discomfort. So if you have 2 or more criteria for a month, you can be considered constipated. Etiology, functional in the 90 or 95% of the cases, is situational. For example, in the diaper removal time, or dietary due to diet changes, or even abuse. Infectious, developmental alterations, ADHD, neurological problems, and family predisposition. On the other hand, the organic one is due to malformations, medications, and digestive diseases. Clinical diagnosis and non-pharmacological treatment. We have to take a look at the clinical history, the personal and family history, for example, the meconium, the duration, the types, and the frequency of those feces. In normal children, we have to look at everything, even how they walk, and from there, all the diseases can be considered, such as cystic fibrosis, which we're going to see in this video, celiac disease, hypothyroidism, Hirschsprung disease, anal malformations, spinal abnormalities, and maybe even sexual abuse. Clinical, there is not a routine. We have to use complementary tests, but they can be done for more in-depth evaluation. These are, for example, ultrasound, abdominal X-ray, anorectal manometry. This is the balloon probe that measures the reflex of ejecting the feces, the barium enema, and the colonic transit studies. These are not usually done, though. Pharmacological treatment, on the other hand, so depending on the phases, we will use laxatives, for example, when there is a disimpaction needed, when there is a fecaloma. For maintenance, we use osmotic laxatives, and we have to take into account withdrawal. So 1 month of control, gradual withdrawal, and risk of relapse. Normalize the constipation is the goal, of course. And to do that, we can take a look at the diet. So implementing dietary measures such as increasing fiber and maybe removing processed food can help us regain that normal motility. Moving on, we have malnutrition. Definition. It occurs in the small intestine because that's where we absorb most of the nutrients. 3 phases of maldigestion, malabsorption: luminal, mucosal, and post-absorptive. It is a consequence of an alteration at any level of the gastrointestinal tract. Once you pass that absorption site of that specific molecule, for example, sugars, it is hardly going to be able to absorb further. Chances are we are not going to absorb sugars in the colon. Diagnosis. Again, the ABCD. So very variable symptoms. Can be very mild, non-specific, with diarrhea, failure to thrive, flatulence, abdominal pain, and so on. The physical examination, cutaneous pallor, fold sign, the jaundice as well, and the kwashiorkor. This is atypical celiac disease. The kwashiorkor is the one related to the protein malnutrition. The medical history and the physical examination. Possible complementary tests such as blood tests and fecal studies. Depending on the suspicion, we have to try different tests, including elimination diet. And the treatment is the one of the underlying cause. And we have to provide nutritional support according to the pathology. And then we have cystic fibrosis. This is the chronic hereditary disease that affects various organs. It is an autosomal recessive. That means it needs 2 mutated copies, aka one from the father and one from the mother. That means that there is 25% probability of getting it from our genes, and of course, is not dominant. Genetic basis. This is a defect in the gene that encodes the CTFR protein. This indeed will create a very thick secretion, a thick mucus. So all the secretions in our body will be much, much thicker. And that's going to create a lot of problems. Clinical manifestations: respiratory, digestive, reproductive, and sweat glands clinical manifestations. Sweat test: very high chloride and sodium. Clinical manifestations: respiratory and digestive symptoms. Pulmonary disease: a thick mucus that cannot be cleared. Accumulation, infection, inflammation, and possible death. Exocrine pancreatic insufficiency: thick secretions that are not well excreted into the duodenum. So guess what? That remains in the organ, causing a self-digestion of the pancreas, seen with steatorrhea, abdominal distension, and gas, failure to thrive, malnutrition, and fat-soluble vitamin deficiency. That's because we are not going to be able to emulsify those fats to absorb them. And the diagnosis can be done with the elastase, when there is a more than 100 in the feces, with the fat in the feces after 72 hours, or using the coefficient of fat absorption, which is the amount of fat that is eaten minus the one that is excreted. And the treatment is using enzymes. Of course, we use exogenous enzymes and we provide vitamins. Nutritional considerations. The enzymes are not needed in fruit juices, fruits, isotonic drinks, and candy. And we must provide a good diet, as it has a significant influence in this pathology. Patients with cystic fibrosis become malnourished because they increase the losses, they have higher energy expenditure, and they lower the intake. It is a vicious circle that leads to the disease. Fats must be 35 to 40%, carbohydrates 40 to 45%, and proteins at 20%. Fat-soluble vitamins, such as vitamin E for everyone, and all the rest according to the needs. These are the supplements, and these external supplements must be administered with pancreatic enzymes to be able to digest the other food. In a malnourished child with cystic fibrosis, a high-calorie and high-fat diet is recommended. Otherwise, we are going to encounter a growth failure. Also, increasing caloric density, caloric food. This is done to attempt weight recovery and ensure the fat intake because of those fat-soluble vitamins. And in case the child deteriorates, we have to give enteral nutrition, as the parenteral one is almost never used. The treatment is with respiratory physiotherapy and mucolytics, together with early antibiotic treatment, optimal nutrition, and pancreatic enzymes. This is the most important thing. And there are also new drugs that have potentiators and correctors. These are channel opening drugs. This is to correct the CTFR protein formation, and modulators to improve the lung function. Some patients with these new drugs could regain the pancreatic function and decrease the sweat chloride. So as a conclusion, the cystic fibrosis is a chronic and hereditary disease. It affects the CTFR protein and it affects the lungs and pancreas mainly. The goal is to maintain the body mass index of the child over the percentile 50. And the nutritional management is with high calories, unsaturated, and simple sugars, so easier to absorb. And we have to provide enzymes and vitamin supplements, as well as sodium, because they are going to lose a lot of sodium in the sweat. And as last chapter of today's video, we talk about dysphagia. It needs a multidisciplinary approach and nutritional assessment. The symptoms are cerebral palsy, constipation, bronchitis, phlegm, unable to measure, and sometimes coughs while eating. The nutritional status is 30 to 50% of malnutrition, depending on the age, the degree of cognitive function, and the motor deficit. On the other hand, 8 to 14% of them are overweight. They are considered non-priority because they are not going to suffer malnutrition, and they are poorly recognized, and they are part of an essential part of the comprehensive care. The assessment of nutritional status is the ABCD, but not like any other child. The alarm signs are the malnutrition, the pressure ulcers, and the poor perfusion. Then also the very low weight. The triceps fold and the arm circumference are very low, and there is no weight gain. It is useful to perform an annual blood test and a bone densitometry. The main problems of these children are all related to the digestive system, and one leads to the other. As you can see, dysphagia will lead to constipation, then to gastroesophageal reflux, gastroparesis, and then to sialorrhea, bruxism, and caries. The diagnosis and management of dysphagia, we have to classify it as a symptom. Dysphagia is a symptom, not a disease, and is usually oropharyngeal and functional, because there are other types of dysphagia as well, but this is the main one, oropharyngeal and functional. There are suspicion alarm signs that we must take in account, and we can do this using the volume viscosity test. This is giving nectar, liquid, and pudding textures, and if there is safety issues, we have to stop. After that, we can calibrate the food texture. We give a modified food texture using nectar, honey, or pudding, creams, and purees to see which one is tolerated better. So for example, when there is a liquid dysphagia, we can use thickeners to create gelled water. And also, natural thickeners are available, such as cornstarch or gofio. If there is a high suspicion of dysphagia, we have to perform complementary analysis. This is using either video fluoroscopy or fibroendoscopy. When oral intake is not possible, we have to opt for the enteral nutrition with gastrostomy. We cannot use the nasogastric one. It's very dangerous in this situation. So gastrostomy, straight to the stomach. We have to consider the dental hygiene, constant pain, the economic level, and the family. And as a recap, it is a child with neurological disability, it has significant difficulties in feeding, and it has evident or subclinical deficits, together with comorbidities, other diseases. Digestive nutritional aspect should be addressed periodically, and this is done through anthropometry and alarm signs detection. And of course, as always, a multidisciplinary approach is required to improve the life quality of the child. Okay, this is it for this video. I hope you understood everything I said. If you didn't, there is a comment section down below. Don't forget to like, subscribe, and turn on the notifications so you get notified every time I upload a new video. If you find value in this, please share it to your friends and family to spread this knowledge to them as well. Thank you so much for watching, and I will see you in the next one, in which we're going to talk about the integrated health disorders. So I will see you there. Hope you enjoyed. Ciao!